we introduce Punct VR, a self-directed VR training framework for image-guided needle puncture. This work represents a strong cross-disciplinary collaboration bringing together academic, industrial, and clinical expertise from Shanghai Jiaotong University, United Imaging Intelligence, Beijing Cancer Hospital, and AstraZeneca. Image-guided needle puncture is a core medical procedure with broad clinical applications. Successful puncture is critical for accurate diagnosis and effective treatment. However, this procedure presents significant challenges. Even experienced clinicians face persistent difficulties during execution. Why? Because it requires high spatial cognition. Physicians must construct a spatial mental model of patient-specific anatomy by scrolling through 2D cross-sectional images. They have to plan a 3D path and insert a needle accurately without seeing the target directly. Precise navigation is required to hit deep targets while carefully avoiding critical structures like blood vessels and bones. For novices, this mental workload is overwhelming. However, current training systems still have their limitations. First, the fidelity bias. Systems heavily invest in high-fidelity physical simulation through costly haptic devices. However, the primary hurdle for novices is not manual dexterity, but the high cognitive load of mentally reconstructing 3D anatomy from 2D slices. Second, the navigation gap. Modern XR aids often act like GPS, providing persistent real-time guidance. This assists immediate execution, but creates dependency. Trainees learn to blindly follow a virtual trajectory, but fail to cultivate the core spatial reasoning needed for independent practice. Finally, the assistance dilemma. The challenge of finding the optimal balance between insufficient guidance that causes failure and overly explicit instruction that can impede true learning. To address these limitations and ensure our system meets genuine clinical needs, we conducted a formative study with a multidisciplinary clinical team. By observing their real-world procedures and trialing an early prototype, we distilled 3 foundational insights. First, the tacit knowledge barrier. Experts often rely on unspoken intuition. Our system must make this implicit expertise explicit through a structured, step-by-step workflow. Second, the assistance dilemma. While powerful 3D guidance improves immediate performance, it risks letting trainees circumvent the core cognitive skill of mentally reconstructing anatomy from 2D views. This leads us to design a study that systematically compares different guidance levels rather than simply offering maximum help. Finally, the need for embodied feedback. Trainees reported the virtual interaction felt empty. This highlighted a critical gap in simulating the tactile sensation of tissue resistance, driving our focus on enhancing procedural realism. Based on the above background, we present Punct VR, a system built upon the instructional principles of scaffolding. Our scaffolding framework consists of 2 primary branches: task deconstruction, which breaks the complex procedure down into a phased workflow of identification, planning, and action. Parallel to this, instructional guidance provides context-aware support through a combination of visual, numerical, and pseudo-haptic aids to effectively reduce cognitive load. Translating these scaffolding into a realistic simulation requires a solid technical foundation. As you can see here, our system utilizes a streamlined pipeline to process actual patient DICOM data into a Unity-based VR environment, deployed seamlessly on standalone hardware. Next, we will detail the scaffolding framework. As for the phase subgoal workflow, Punct VR breaks down the complex needle puncture procedure into 3 manageable phases. It starts with phase 1, target lesion identification, which focuses on helping trainees build a 3D mental model from 2D scan slices. In subgoal 1.1, the trainee analyzes 2D slices to identify the target lesion and understand its relationship with adjacent tissues. In subgoal 1.2, the trainee makes a high-level strategic decision regarding the patient's surgical orientation, such as selecting a supine position. Phase 2 focuses on defining a safe and effective needle access route, targeting the skill of mental planning. This phase is deconstructed into 3 subgoals. First, in subgoal 2.1, the trainee selects the optimal axial plane for clear visualization and targeting. Next, in subgoal 2.2, they define the trajectory and use virtual tools to measure critical clinical distances. Finally, in subgoal 2.3, they locate the skin puncture site, establishing a robust link between the 2D image space and the 3D patient model. The final phase trains the dynamic skill of mental manipulation through an iterative loop between 2 subgoals. In subgoal 3.1, the trainee advances the needle along the planned trajectory. To receive feedback, they complete subgoal 3.2 by triggering a simulated CT scan to acquire new visual data of the needle's actual path. This allows them to update their mental reference frame for the next action until the lesion is successfully reached. Parallel to the phase subgoal workflow, instructional guidance provides 2 distinct forms of visual guidance. On the left, you see the standard NPR view, which replicates current clinical practice. It displays only stacking 2D slices, forcing the trainee to mentally reconstruct the 3D anatomy. Now look at the right. Our enhanced view provides a full 3D visualization, offering see-through vision that makes the anatomical relationships much easier to understand. Besides 3D visualizations, numerical guidance addresses cognitive burdens by redefining perceptual estimation as data monitoring. A real-time insertion depth indicator and angular deviation display transform complex spatial positioning into simple, trackable metrics. Furthermore, pseudohaptics simulates tissue resistance without physical hardware, using software-driven dynamic control display ratio manipulation. To counter the emptiness felt in virtual environments, we add a visual force indicator. It uses a dashed line to display the magnitude of simulated resistance, thereby bridging the gap between visual feedback and tactile intuition. To integrate these scaffolding strategies, Punkt VR employs a dual-mode learning cycle. First, in training mode, trainees are fully supported by our comprehensive learning scaffolding to systematically build their spatial and procedural skills. Second, in test mode, we remove all task deconstruction scaffolding and enhance 3D visualization to replicate the conditions of current clinical practice. This allows us to accurately evaluate skill acquisition, as trainees must complete the procedure relying entirely on their internalized knowledge. To evaluate the effectiveness of this training framework, we conducted a between-subject study. We compared 2 visualization conditions, standard NPR and a combined NPR with a 3D view. We successfully recruited 16 participants. Each participant performed the simulated needle puncture under 2 distinct difficulty levels, an easy case and a hard case. Our procedure started with VR familiarization and a baseline pretest. Participants then completed a 20-minute condition-specific training session, followed immediately by a post-test and questionnaire. After a brief rest, they repeated this cycle for the 2nd difficulty level. Finally, we conducted interviews to gather qualitative feedback on the system. Our results showed that scaffolding works. All participants significantly improved their performance within the VR system after training. Participants who used the enhanced 3D guidance in training mode showed significantly higher efficiency when they moved to test mode. This suggests that the 3D scaffolding helped them internalize the spatial relationships more effectively. Corroborating the performance gains from the previous slide, our interviews reveal why the system succeeded. Scaffolded training noticeably reduced cognitive load. Integrated 3D visualization offered an intuitive grasp of complex anatomies, driving strong motivation for continued self-practice. Finally, participants found our pseudo-haptic feedback transparent rather than restrictive. To conclude, our study introduces Punct VR, a self-directed VR training framework for image-guided needle puncture. We demonstrated that decomposing complex procedures into phased subgoals significantly improves performance. Notably, participants using integrated 3D visualization achieved greater procedural efficiency, and importantly, these internalized spatial skills persisted even after 3D guidance was withdrawn in Punct VR. Finally, Punct VR presents a highly scalable solution. The design principles validated here lay a strong foundation for accessible training methodologies that can be readily adapted to other spatially complex medical procedures. Thank you for your attention, and we welcome any questions.